Welcome to Merit 360. Today we are diving into an important topic, the management of diabetes. In this episode of my diabetes series, we will focus specifically on the medications used to treat diabetes. We will explore their doses, mechanism of actions, properties, types, and the potential side effects. Everything you need to understand how these therapies work. So if you are looking to gain clear and concise knowledge about diabetes treatment, you are in the right place. So let's get started. In today's lecture, I will be talking about the different therapies used in diabetes. To make it simple, I have classified them into two main types. The first one is non-insulin therapies, which include both oral and injectable medications. And the second one is insulin therapy. I will be starting with exploring the non-insulin therapies in detail, and then we will move on to the insulin therapy. Today I will be discussing the 11 non-insulin medications used in the diabetes treatment. Most of these are specifically for type 2 diabetes, with only a few being used in type 1 diabetes. This is because, as we all know, type 1 diabetes is an autoimmune disease that causes absolute insulin deficiency. These patients require insulin to survive, as other medications don't work effectively for them. The best and the most proven treatment for type 1 diabetes is therefore insulin. In contrast, the type 2 diabetes occur due to body's resistance to insulin and a relative insulin deficiency. Since the pancreas still produces some insulin, many medications can help in the early management of type 2 diabetes. However, if the blood sugar isn't controlled properly with these medications, some patients may eventually need insulin therapy. Now, let's go over the 11 non-insulin therapies used in diabetes. Number 1 is biguanides, with the most well-known medication is Metformin. Number 2, sulfonylureas or SUs. Number 3, dipeptidyl peptidase 4 inhibitors or DPP4 inhibitors. Number 4, thiazolidinediones or TZDs. Number 5, glucagon-like peptide 1 receptor agonists or GLP-1 agonists. Number 6, sodium glucose cotransporter 2 inhibitors or SGLT2 inhibitors. The rest of the 5 medications are used less commonly in the management of type 2 diabetes mellitus. Number 7, meglitinides. Number 8, alpha-glucosidase inhibitors like for example acarbose. Number 9, bile acid sequestrants like colesevelam. Number 10, bromocriptine, a dopamine agonist. And lastly, number 11, pramlintide, which is an amylin analog. Among all the non-insulin medications, only the pramlintide is officially FDA approved for the use in the type 1 diabetes. Other drugs like metformin, SGLT2 inhibitors, GLP-1 receptor agonists have been studied in type 1 diabetes, but their effects have been minimal, showing only small reductions in the weight and blood glucose levels. This reinforces the fact that for type 1 diabetes, the most effective and essential treatment remains insulin therapy. On the contrary, in type 2 diabetes, where the insulin resistance and relative insulin deficiency are the main issues, these non-insulin medications play a crucial role in the treatment. Many of them help lower the blood sugar, improve insulin sensitivity, or reduce the glucose absorption, delaying the need for insulin in a significant number of patients. Now that I have listed them, let's go deeper into how each one works. Let's start with biguanides. The medications in this class are metformin and metformin extended release. Metformin is the first-line drug for almost all patients with type 2 diabetes unless there are contraindications. It's widely used because of its effectiveness, affordability, and low risk of hypoglycemia. So, how does this metformin work? It works by reducing the gluconeogenesis, that is, it lowers the glucose production in the liver. It also improves insulin sensitivity, helping the body cells use insulin more effectively. And lastly, it decreases the glucose absorption in the intestines, limiting the amount of sugar entering the bloodstream. This makes metformin an excellent choice for managing blood sugar levels while also being weight neutral and well tolerated by most patients. Now let's move on to the next class of medication, sulfonylureas, also known as SUs. This class includes medications like glimepiride, glipizide, glyburide, and gliclazide. Sulfonylureas are often called insulin secretagogues, meaning that they work by stimulating the pancreas to secrete more insulin. By increasing the insulin release, these medications help lower blood sugar levels, making them an important part of the treatment for type 2 diabetes mellitus. Next we have is the dipeptidyl peptidase 4 inhibitors, often shortened to DPP4 inhibitors. This class includes sitagliptin, linagliptin, saxagliptin, and alogliptin. These are sometimes casually referred to as the gliptins due to their common suffix. The DPP4 inhibitors, they work by blocking the enzyme DPP4, which is responsible for breaking down incretins such as glucagon-like peptide 1 and gastric inhibitory polypeptide. By inhibiting the DPP4 enzyme, these medications increase the level of GLP-1 and the GIP, which in turn stimulate insulin secretion from the pancreas in response to meals. This helps lower the blood glucose levels. Additionally, the GLP-1 helps reduce the glucagon secretion, which prevents the liver from producing too much glucose. In summary, the DPP4 inhibitors enhances the body's natural ability to regulate insulin and glucose production, making them an effective treatment option for type 2 diabetes. The fourth class of medications is thiazolidinediones or TZDs. They are commonly referred to as glitazones because of their common suffix. This class includes pioglitazone and rosiglitazone. The TZDs work by activating a specific nuclear transcription factor called the PPAR gamma or peroxisome proliferator activated receptor gamma. When the PPAR gamma is activated, it triggers a cascade of biological processes that improve the insulin sensitivity in various tissues, including muscles, fats, and liver cells. By increasing the insulin sensitivity, the TZDs help the body use insulin more effectively, allowing glucose to be taken up by the cells more efficiently. This helps lower the blood glucose level. The fifth class of medication is glucagon-like peptide 1 receptor agonists, also known as GLP-1 agonists. This class includes exenatide, semaglutide, liraglutide, and dulaglutide. The GLP-1 agonists work by mimicking the body's natural incretin GLP-1. As we have discussed earlier in the mechanism of action of the DPP4 inhibitors, the GLP-1 incretin plays a crucial role in increasing the insulin secretion after meals, decreasing the glucagon production, and reducing the glucose production by the liver. In addition to these effects, the GLP-1 agonists also have other important benefits like slowing the gastric emptying, which helps control the speed at which food moves through the digestive system, leading to increased feeling of satiety or fullness. This can help with the weight loss in patients with type 2 diabetes as it reduces the overall food intake. Overall, the GLP-1 agonists are a powerful tool in managing blood glucose levels, improving the insulin secretion, and helping with the weight management, making them an excellent option for many patients. The next class is an exciting one, sodium glucose cotransporter 2 inhibitors or SGLT2 inhibitors. This class includes empagliflozin, dapagliflozin, and canagliflozin. The SGLT2 inhibitors work by blocking the glucose reabsorption in the kidneys. Normally, glucose is filtered to the kidneys and reabsorbed back into the bloodstream. But by inhibiting the SGLT2 protein, these medications prevent the glucose from being reabsorbed. This results in the increased loss of glucose in the urine, a process called glycosuria. By promoting the excretion of excess glucose through the urine, the SGLT2 inhibitors help lower the blood glucose levels. Additionally, they have the added benefit of promoting weight loss, thus making them an excellent choice for patients with type 2 diabetes, especially those who are overweight. Up until now, we have discussed the 6 most commonly used medications in diabetes. These include metformin, sulfonylureas, DPP4 inhibitors, TZDs, GLP-1 agonists, and SGLT2 inhibitors. Now let's move on to some less commonly used medications. The seventh class is meglitinides, which are also known as insulin secretagogues, similar to sulfonylureas. This class includes medications like netiglinide and repaglinide. Like the sulfonylureas, the meglitinides work by stimulating insulin secretion from the pancreas. However, they differ from SUs in a few important ways. Number one, they have a faster onset of action and shorter duration of action. Meglitinides are rapid acting, meaning that they start working quickly after you take them, but their effects wear off much faster compared to SUs. This makes them particularly useful for controlling the blood sugar immediately after meals. The second way in which they are different from the SUs is that, unlike the SUs, the meglitinides are typically taken just before meals, which allows them to target the post-meal blood sugar spikes more effectively. So this makes the meglitinides a good option for patients who have a higher blood sugar after meals, but they don't require a higher insulin around the clock. However, because they are rapid acting, they may need to be adjusted depending upon the patient's individual meal patterns. The eighth class of medication is alpha-glucosidase inhibitors. This class includes acarbose and miglitol. Alpha-glucosidase inhibitors work by slowing the absorption of dietary carbohydrates in the small intestine. They do this by inhibiting the action of the alpha-glucosidase enzymes, which are responsible for the breaking down complex carbohydrates like starches into simple sugars such as glucose. By slowing down this process, alpha-glucosidase inhibitors delay the breakdown of carbohydrates into glucose. This means that the glucose is released into the bloodstream more gradually rather than causing a rapid spike in the blood sugar levels after meals. This lower absorption results in the lower postprandial blood glucose levels, which is particularly important for managing type 2 diabetes, where the patient often experiences a sharp blood glucose rise after eating. By preventing these rapid glucose spikes, acarbose and miglitol help improve the overall blood sugar control and reduce the risk of hyperglycemia following meals. The ninth class of medication is bile acid sequestrants, and the most commonly used drug in this class is colesevelam. The colesevelam work by decreasing the bile acid reabsorption in the intestines. Normally, bile acids are produced by the liver, stored in the gallbladder, and then released into the intestine to help with the digestion of fats. Bile acid sequestrants bind to these bile acids in the intestines, preventing their reabsorption. While the exact mechanism of how this leads to a reduction in the blood glucose level is still largely unknown, but it is believed that the reduction in the bile acid reabsorption may have an impact on the insulin sensitivity and the glucose metabolism. The 10th class of medication is dopamine agonists, with bromocriptine being the primary drug in this class. Bromocriptine works by activating the central dopamine D2 receptors in the brain. These receptors are part of the dopaminergic system, which helps regulate the processes like insulin sensitivity and glucose metabolism. When bromocriptine activates these dopamine receptors, it leads to improved insulin sensitivity and reduce the glucose production by the liver. This can help lower the blood sugar levels in patients with type 2 diabetes. Last but certainly not least, we have amylin analog medications, and the most commonly used drug in this class is pramlintide. Pramlintide is the only FDA-approved non-insulin therapy that can be used in type 1 diabetes. Pramlintide works by decreasing the glucagon secretion, which in turn leads to reduced hepatic glucose production. Glucagon normally signals the liver to produce glucose, so by inhibiting this, pramlintide helps control the high blood sugar levels. In addition to its effect on glucagon, pramlintide also slows gastric emptying, which helps reduce the postprandial blood glucose spikes by preventing the food from moving too quickly through the digestive system. This effect, combined with an increased satiety, helps the patient feel fuller for longer and can aid in the weight management, which is often beneficial for type 2 diabetes management. While pramlintide is an important treatment for type 1 diabetes, it generally used in combination with insulin therapy, as it complements the insulin action without replacing it. Alright, so we have covered all the non-insulin therapies. Now let's do a quick recap to lock it all in. First up, metformin. It's our go-to first-line therapy. It works by reducing the glucose production in the liver, that is, decrease the gluconeogenesis, improving insulin sensitivity, and reduces the glucose absorption in the intestines. Next, we have sulfonylureas or SUs. These work by increasing the insulin secretion from the pancreas. Simple and effective, but they come with the risk of hypoglycemia. After SUs, we have DPP-4 inhibitors that also increase the insulin secretion and also decreases the glucagon levels, but they do this by blocking the DPP-4 enzyme, which helps prolong the action of incretins. Now, thiazolidinediones or TZDs, these improve the insulin sensitivity mainly by activating the PPAR gamma receptors, making cells more responsive to insulin. Moving on to the GLP-1 receptor agonists, they have multiple actions. They increase the insulin secretion, decrease the glucagon secretion, slows the gastric emptying, and increase satiety. Then we have SGLT2 inhibitors. These work by blocking the glucose reabsorption in the kidneys, leading to increased glucose excretion in the urine. They can help with the weight loss and also reduce the cardiovascular risk. Then we have meglitinides. They work similar to the sulfonylureas by stimulating the insulin secretion, but they have a shorter duration of action, so they are often taken before meals. Coming to the alpha-glucosidase inhibitors, they work by slowing the absorption of dietary carbohydrates in the intestines, which means a slower rise in the blood sugar after meals. Then we have colicivilam, a bile acid sequestrant. It decreases the bile acid reabsorption, and while we don't fully understand how it lowers the blood glucose, it does have that effect. Next we have bromocriptine, which is a dopamine agonist. It's thought to reduce the gluconeogenesis and improve the insulin sensitivity, though the exact mechanism isn't entirely clear. And finally, pramlintide. This is an amylin analog that decreases the glucagon secretion, delays the gastric emptying, and increases the satiety, which can be useful for the post-meal glucose control. That's it, a quick refresher on how these medications work. Alright, now that we understand how these medications work, let's go a little deeper into their details. I will go over some of the key characteristics like how we take them, oral or injection, how much they help lower the HbA1c levels, and whether they carry a risk of hypoglycemia. We will also talk about their impact on the weight. Do they cause weight gain, weight loss, or have no effect? Then we will look at their effects on the major health conditions like atherosclerotic cardiovascular disease, heart failure, and diabetic kidney disease. And finally, I will cover some of the most common and important side effects you should know. So let's break it down step by step. Alright, let's start with metformin. Metformin is an oral medication, meaning that we take it by mouth. It helps lower the HbA1c levels by about 1 to 2%, which is pretty solid. One big advantage that it doesn't cause hypoglycemia, so there is no risk of low blood sugar. Now when it comes to weight, metformin is either weight neutral or might even help with a little weight loss. But the real bonus is that it has proven benefits in reducing the cardiovascular events, meaning that it helps protect the heart. However, it doesn't have a significant impact on heart failure or diabetic kidney disease. As for the side effects, the most common ones are nausea and diarrhea, especially when you first start taking it. There's also a rare but serious risk of lactic acidosis, though that usually happens in people with kidney disease. And with long-term use, it can lead to vitamin B12 deficiency, so it's a good idea to keep an eye on that. So that's metformin in a nutshell. Let's move on to the next one. Next is sulfonylureas or SUs. These are taken orally and lowers the HbA1c by about 1 to 2%. But the downside is that they do increase the risk of hypoglycemia. They also cause weight gain, which isn't ideal for some patients. When it comes to the heart disease, heart failure, and kidney disease, they don't really have any major side effects or benefits. They are pretty neutral. The main concerns are hypoglycemia and weight gain. Next, DPP-4 inhibitors. These are also taken by mouth and they lower the HbA1c by about 0.5 to 0.8%. The good news though is that it does not cause any risk of hypoglycemia. They are also weight neutral, so they don't cause weight gain or weight loss. They don't have any significant effects on the heart disease either, but there is a potential risk of heart failure, particularly with sexagliptin. Another thing to watch out for is joint pain and an increased risk of pancreatitis. Moving on to the TZDs, these are oral medications that lower the HbA1c by about 0.5 to 1.4%. No risk of hypoglycemia, but they do cause weight gain. Pioglitazones may have some cardiovascular benefits, but TZDs overall come with an increased risk of heart failure. They are neutral when it comes to the kidney disease, but they can cause edema, fractures, and possibly even bladder cancer. So definitely not the first line choice for everyone. Okay, so now let's talk about the GLP-1 receptor agonists. Most of these are subcutaneous injections, but semaglutide also come in an oral form. They lower the HbA1c by about 0.5 to 1%, and the good thing is that they don't cause hypoglycemia. Another major benefit is that it reduces weight. Plus, some of these medications like dulaglutide, liraglutide, and semaglutide have been shown to reduce the cardiovascular events. They don't have a big impact on the heart failure, but they do show benefits for kidney disease in certain trials. Side effects, yes, they do, and they are curious ones, and they can cause injection site reactions, a possible risk for thyroid cancer, and acute pancreatitis. Another important class of medications are the SGLT2 inhibitors. These are oral medications that lower the HbA1c by about 0.5 to 1%. They don't cause hypoglycemia and they can actually promote weight loss. But their real strength lies in that they are excellent for the heart and kidneys. These drugs reduces the cardiovascular events, help in the heart failure, and provide kidney protection. Sounds great, right? Well, they do come with risk, including urinary infections, lower the blood pressure, and in some cases, amputations, fractures, diabetic ketoacidosis, and even for near gangrene, a rare but serious infection. Next we have are the less commonly used medications. The number one is the alpha-glucosidase inhibitors. These are taken orally and lowers the HbA1c by about 0.5 to 0.8%. There is no risk of hypoglycemia and they are actually weight neutral. They don't have any significant effects on the heart disease, heart failure, or kidney disease. But they can cause some annoying side effects like flatulence and increase the liver enzymes. Then there are meglitinides. These oral medications lower the HbA1c by about 0.5 to 1%, but they do come with the risk of hypoglycemia. They also cause weight gain. They don't have any major effects on the heart disease, heart failure, or kidney disease. But their main downside is that just like sulfonylureas, they can cause low blood sugar and weight gain. And finally, pramlintide, an amylin agonist. This one is a subcutaneous injection that lowers the HbA1c by about 0.25 to 0.5%. It does carry a risk of hypoglycemia, especially when used with insulin, but it also helps with the weight loss. It doesn't have any significant impact on the heart disease, heart failure, or kidney disease. However, the common side effects include injection site reactions, nausea, and a risk of hypoglycemia if used alongside with insulin. So that was a breakdown of the key features of anti-diabetic medications. Now, in the next and the final section on the non-insulin therapies, I will go over the starting doses and the recommended doses of some of the most commonly used medications. Plus, I will also explain how to adjust these medications in patients with renal insufficiency, something we often see in diabetes management. So let's get into it. Let's start with metformin, the go-to medication for most people with type 2 diabetes. It usually starts at 500 mg once or twice daily to help the body use insulin more effectively. The recommended dose is about 1000 mg twice daily for maximum effect. But here's the catch. Metformin isn't safe for everyone. If the kidney's function is compromised, things can get tricky. If the eGFR drops below 30, metformin is a no-go. But if it's between 30 and 40, starting metformin isn't recommended. The extended release version Metformin XR follows the same rule, but it allows for a smoother ride with fewer stomach issues. The starting dose is about 500 to 1000 mg once daily, and the recommended dose is about 1000 mg twice daily or 2000 mg once daily. Moving on to the sulfonylureas, the classic insulin secretagogues, glimepiride kicks off at 1 to 2 mg once daily with a typical recommended dosage of around 4 mg daily. But for those with kidney issues, the risk of hypoglycemia is real, so it's best to start at just 1 mg daily. Glipizide follows a similar pattern beginning at 5 mg daily and a recommended dose of about 5 mg once daily. But in those with kidney problems, a cautious 2.5 mg starting dose is recommended. Then we have the DPP-4 inhibitors. The sitagliptin is usually taken at 100 mg once daily and the recommended dose is about the same, that is 100 mg daily. But the kidney function matter here as well. If the eGFR falls below 30 to 50, the dose is cut to about 50 mg once daily. But if the eGFR falls below 30, then reduce the dose to about 25 mg once daily. On the other hand, linagliptin is the exception. No dose adjustments needed no matter the kidney function. The starting dose is about 5 mg once daily with the recommended dose of about 5 mg once daily as well. Okay, let's talk about TZDs, the drugs that improve the insulin sensitivity over time. Pioglitazone starts at 15 mg once daily and can be bumped up to 30 mg once daily. No kidney dose adjustments are needed. Same goes for the rosiglitazone, which can be taken as 4 mg once daily or 2 mg twice daily with no need to worry about the kidney function. Coming towards the SGLT2 inhibitors, dapagliflozin starts at 5 mg once daily and can go up to about 10 mg once daily. But if the eGFR drops below 60, it should be avoided. Empagliflozin works similarly with a starting dose of about 10 mg once daily, which can increase to 25 mg once daily. But it's not recommended if the eGFR falls below 30. Then we have the GLP-1 receptor agonists. Exenatide starts at 5 microgram twice daily and can be increased to 10 microgram twice daily. But it's not an option if eGFR is below 30. Lexisinatide follows suit with 10 microgram once daily, increasing to 20 microgram once daily. But it's off the table if eGFR is below 15. What about the weekly injectables semaglutide? Semaglutide starts at 0.25 mg once weekly with a goal of 1 mg once weekly, and no renal adjustments are needed. Liraglutide begins at 0.6 mg daily and can go up to about 1.8 mg daily, again without concerns for kidney function. Lastly, the oral pill version of semaglutide starts at 3 mg once daily, increasing to about 14 mg once daily, with no dose changes needed for the kidney function. So, whether you are starting metformin, considering sulfonylureas, or looking into newer options like SGLT2 inhibitors and GLP-1 receptor agonists, the kidney function plays a key role. Some drugs need careful dose adjustments, while others are best avoided altogether. Knowing when and how to adjust these medications can make all the difference in safe and effective diabetes management. That was all about the non-insulin therapies in diabetes mellitus. I hope this session was informative, very easy to understand, and helpful in clarifying the different classes of medications, their doses, and how they should be adjusted in renal insufficiency. But now it's time to move on to the next big topic, that is insulin. We will break it down step by step, covering the different types of insulin, what are their characteristics, what are the different side effects, and how to use the insulin with some educational tips. So stay tuned and you will learn more. A gentle reminder to the viewers that if you have made it this far and found this video helpful, don't forget to hit that subscribe button to stay updated with more educational content. Like this video, share it with others, and let's spread the knowledge. Alright, let's dive into the insulin therapy, an essential part of the diabetes management. Insulin is characterized based on how fast it works and how long it lasts. These categories include ultra rapid acting, short acting, intermediate acting, and long acting insulins. Ultra rapid acting insulin, and short acting insulin are characterized as bolus insulin, whereas the intermediate acting insulin and the long acting insulin are grouped together as basal insulin. Think of the bolus insulin as your mealtime insulin. It's fast acting and helps control the blood sugar spikes that occur after eating. While the basal insulin is your background insulin that works all day long to keep the blood sugar stable when you are fasting or between meals. Now that we understand how insulin is categorized, let's go through the actual insulin products in each category. The ultra short acting insulin, they work super fast almost immediately after injection. These include insulin aspart, which is FIASP, fast acting insulin aspart, insulin lispro AABC, and inhaled human insulin. So what about the rapid acting insulin? These are also fast but not as quick as the ultra short acting ones. They have insulin aspart, insulin lispro, and insulin glulicine. And lastly, in the bolus category, the short acting insulin. This is your traditional regular insulin which takes a bit longer to kick in but still acts fast enough to be used for mealtime coverage. Let's talk about the basal insulin. The first category is intermediate acting insulin. The main one here is the neutral protamine hagedorn insulin. And lastly, in the basal insulin, the second category is the long acting insulins. They provide a steady insulin level throughout the day with minimal peaks. They include insulin detamers, glargine, and degludec. All of these are commonly available in a U100 per ml concentration, meaning that 100 units per milliliter. However, for patients who require higher doses of insulin, we have stronger versions like U200, U300, or U500. These higher concentration insulins are particularly useful for patients with insulin resistance who need larger amounts but want to reduce the injection volume. Okay, if managing multiple injections sounds overwhelming, combination insulins are also available. These combination products include an intermediate or long-acting insulin for the basal coverage with a short or rapid-acting insulin for the mealtime spikes. These pre-mixed insulins make life a little easier as they reduce the number of injections and still provide effective blood sugar control similar to a full basal bolus regimen. These pre-mixed insulin include 70% NPH with a combination of 30% regular insulin, or a 75% NPH insulin with 25% lispro, 50% NPH or 50% lispro, and 70% aspart protamine with 30% aspart insulin. Okay, before we jump in, let's quickly define two important terms, pharmacokinetics and pharmacodynamics. The pharmacokinetics is how the body absorbs, distributes, metabolizes, and eliminates insulin. while the pharmacodynamics refer to how insulin actually works in the body to lower the blood sugar. Now let's talk about the key factors that can affect the insulin's pharmacokinetics and pharmacodynamics. Two important key factors affect the pharmacokinetics and the pharmacodynamic properties of insulin. Number one is making of faster acting insulins, and number two, the insulin absorption. First, we will talk about why faster acting insulins were created. Scientists have modified the regular insulin to create faster acting analogs because the traditional insulin took too long to start working after injection. Imagine that you are eating a meal and your insulin is kicking in too late. That will lead to a high blood sugar after meals. By tweaking the insulin molecules, we get a rapid acting insulin which works almost immediately, making them much better at controlling the post-meal blood sugar spikes without the long waiting time. The second key factor is the insulin absorption. How well insulin is absorbed in your bloodstream can vary from person to person and even from one injection to another. Here's what plays a role. The injection site: insulin absorbed fastest when injected into the abdomen and slower in the arms and slowest in the thighs and buttocks. Number two, thickness of the subcutaneous tissue. The more fat under the skin, the slower insulin absorbs. That's why people with more body fat may need longer acting formulations. Number three, subcutaneous blood flow. That is, more blood flow equals faster absorption. If a person is exercising or massaging the area, insulin will absorb faster. Number four, skin temperature. Warmer skin, like after a hot shower or a workout, speeds up the absorption, while cold temperatures slow it down. And lastly, the amount of insulin injected. That is, larger doses take longer to absorb because the insulin forms a depot under the skin, breaking down gradually, and the smaller doses acts faster. So next time you take insulin, remember that it's not just about the dose, but also where, how, and when you inject it. Alright, let's break it down in a way that actually makes sense when you are using insulin in the real life. Timing matters a lot because it helps decide when to inject and what to expect after taking insulin. So let's go step by step through the different types. First of all, the ultra-rapid acting insulins. These are the fastest one. They work super quickly, making them great for controlling the post-meal glucose spikes. They are absorbed almost immediately, so you need to take them just before or with your meal. First up is the fast-acting insulin aspart. It kicks in within about 15 to 20 minutes with a peak of around 90 to 120 minutes, and it stays in your system for 5 to 7 hours. Next is insulin lispro AABC. It starts working in about 15 to 17 minutes, peaks at about 120 to 174 minutes, and lasts for about 4.6 to 7.3 hours. And then we have the inhaled human insulin. This one is the absolute fastest. It works in just 3 to 7 minutes, peaks in 12 to 15 minutes, and clears out of the body in 2.5 to 3 hours. Let's now discuss the rapid acting insulin. These are ideal for mealtime coverage. They act quickly but not as aggressively as the ultra rapid insulins. The insulin aspart, lispro, and glulicine all work in a similar way. They all starts working in about 10 to 20 minutes, peak between 30 to 90 minutes, and stick around for 3 to 5 hours. And the last of the bolus insulin, that is the short-acting insulin, the old school meal insulin. This is your regular insulin, the traditional choice before rapid-acting insulins became common. It still works well but takes longer to kick in, so you have to inject it earlier before meals. The regular insulin onset of action is about 30 to 60 minutes, peak around 2 to 4 hours, and the duration of action is about 5 to 7 hours. Now, if someone needs higher doses, they might use the concentrated regular insulin U500. It starts working in about 30 minutes, peaks between 4 to 8 hours, and can last anywhere from 13 to 24 hours. Now coming to the category of the basal insulins, I will first talk about the intermediate acting insulins, which are halfway between the short and the long acting insulin. This is used for the background coverage, keeping the blood sugar stable for part of the day. The NPH insulin, that is the neutral protamine hagedon, it takes about 2 to 4 hours to start working, peaks between 4 to 10 hours, and lasts about 10 to 24 hours. And finally, the long-acting basal insulins, the all-day coverage. These are basal insulins providing steady coverage for 24 hours or more. Insulin detemir, it kicks in about 1.5 to 4 hours after injection, peaks around 6 to 14 hours, and lasts 16 to 20 hours. Insulin glargine, it starts working in 2 to 4 hours, no peak, so it provides steady insulin throughout the day and lasts a full 24 hours. And finally, the longest lasting insulin, digludec, it starts in about 1 hour, no peak, meaning very smooth action throughout the day, and lasts a whopping 42 hours. So when choosing an insulin, timing is everything. If you need a quick meal coverage, go for ultra rapid or rapid acting insulin. If you need a steady background insulin, then go for the long acting insulin. And for those who need a bit of both, there are pre-mixed options that combine different types. Let me give you few examples of the pre-mixed insulin. For example, 70% NPH with 30% regular insulin, that is present in the Humulin 70/30 preparation. Its onset of action is about 30 to 60 minutes with a dual peak and duration of action of about 10 to 16 hours. Another preparation is 70% aspartate protamine with 30% aspartate, which is found in the Novolog 70/30 preparation. The onset of action is about 5 to 15 minutes, peak dual, and a duration of 15 to 18 hours. This dual peak in the pre-mixed insulin occurs because it contains both a rapid or short-acting insulin, which peaks early, and an intermediate-acting insulin, which peaks later on. This results in two distinct peaks in the insulin activity, covering both the mealtime glucose spikes and the longer-lasting basal needs. Now let's talk about a very important aspect of the insulin therapy, that is the side effects of insulin therapy. Insulin can cause hypoglycemia, that is low blood sugar. Hypoglycemia is one of the most significant side effects of insulin. It is classified into 3 levels. In level 1, the blood sugar drops below 70 mg per dl but stays above 54 mg per dl. At this stage, the symptoms may start appearing, but the person can usually manage it themselves by consuming carbohydrates. In level 2, the blood sugar falls below 54 mg per dl. This is a more serious stage that increases the risk of cognitive impairment. In level 3, this is the severe hypoglycemia, where the blood sugar may still be above 54 mg per dl but is low enough to cause altered mental or physical status requiring assistance from another person. Some common symptoms of hypoglycemia include shakiness, irritability, confusion, palpitations, hunger, sweating, and impaired concentration, cognition, or reaction time. If untreated, it can progress to seizures or unconsciousness. The second side effect is weight gain. Insulin promotes glucose uptake and storage, which can lead to increased fat accumulation and weight gain, especially if the caloric intake is not adjusted accordingly. And another side effect is the injection site reactions and lipohypertrophy. Repeated insulin injections at the same site can lead to redness, swelling, or irritation. Over time, it may also cause lipohypertrophy, where the fatty lumps develop under the skin, affecting the insulin absorption and also leading to unpredictable blood sugar levels. Let's talk about how to manage these adverse effects if they occur. For managing hypoglycemia, if the blood sugar level is low, immediately consume 15 grams of fast-acting carbohydrates such as half cup of fruit juice, 1 tablespoon of honey, or a few hard candies. Recheck the blood sugar in 15 minutes. If it's still low, then repeat the process. In case of severe hypoglycemia where the patient is unconscious or unable to eat, treatment includes IV hypertonic glucose and glucagon injections. For managing weight gain, adjust the caloric intake to balance the insulin's effect on the fat storage. Lifestyle modifications like increasing the physical activity can help, and GLP-1 receptor agonists can be considered as they promote weight loss and may complement the insulin therapy. For managing injection site reactions and hypolipoproteinemia, use the correct injection technique to minimize irritation. Rotate the injection sites to prevent lipohypertrophy and ensure even insulin absorption. Okay, let's talk about how insulin is used in the treatment of type 1 diabetes. Type 1 diabetes, as we all know, is caused by an autoimmune destruction of the pancreatic beta cells, leading to an absolute deficiency of insulin. This means that the insulin therapy is not just an option, it's a necessity. The mainstay of treatment for type 1 diabetes is intensive insulin therapy. This involves using multiple daily injections of insulin, both basal and bolus, or the use of an insulin pump to closely mimic the normal insulin secretion of a healthy pancreas. You might also hear this approach referred to as physiological insulin therapy, multiple component therapy, or a basal bolus insulin therapy. Okay, so how does this intensive insulin therapy work? It ensures a continuous basal insulin coverage while also providing bolus insulin bursts to manage the rise in blood sugar after meals. A long-acting insulin is injected once or twice daily to maintain the basal insulin levels. This accounts for about 50% of the total daily insulin dose. The role of the basal insulin is simple. It should provide the background insulin coverage independent of the food intake. On the other hand, the rapid-acting, ultra-rapid-acting or short-acting insulin is injected before meals as bolus insulin. This helps manage the glucose spikes that occur after eating. Among these options, the rapid-acting and the ultra-rapid-acting is preferred over the short-acting insulin because it has a faster onset of action and a shorter duration of action, making it more physiologic and reducing the risk of hypoglycemia. Okay, so now how do we determine the insulin dose? When starting the insulin therapy in type 1 diabetes, we calculate the total daily insulin dose based on weight. The standard starting range is 0.4 to 1 units per kilogram of the body per weight. Once we have the total daily dose, half of which is given as a basal insulin and the other half is divided as bolus insulin across meals. From here, insulin doses are titrated, adjusted based on the blood glucose monitoring. Bolus doses are further refined using carbohydrate counting and the correction dosing to better match the insulin needs of the food intake and glucose levels. The intensive insulin therapy is complex because it requires multiple daily injections or pump boluses, frequent blood glucose monitoring, collaboration between the patient and the healthcare provider. So the most successful insulin therapy involves continuous adjustments based on the nutritional intake, the glucose level, the physical activity, and the stress levels. To fine-tune the insulin dosing, we rely on self-monitoring of blood glucose, carbohydrate to insulin ratios, and the correction factors to modify the insulin according to glucose level. By using these strategies, we can personalize the insulin therapy for each patient, helping them achieve the best possible glucose control while minimizing the risk of hypoglycemia. Here we go with the last section of this lecture. How is insulin used in the treatment of type 2 diabetes? The approach to insulin use in the type 2 diabetes is different from that in the type 1 diabetes. People with type 2 diabetes can often manage their conditions with lifestyle modifications including caloric intake control, physical activity, exercise, and non-insulin medications for years before needing insulin. These medications include metformin, sulfonylureas, DPP-4 inhibitors, thiazolidinediones, GLP-1 receptor agonist, and SGLT2 inhibitors. However, due to the progressive nature of type 2 diabetes, many patients will eventually require insulin to achieve the glycemic control. Current treatment guidelines suggest a stepwise approach to the insulin therapy. First-line injectable therapy like a glucagon-like peptide 1 receptor agonist is preferred before insulin because it has a comparable glucose-lowering effects, it carries a low risk of hypoglycemia, and it has a more favorable effect on weight. If additional glucose lowering is needed after maximizing the glucagon-like peptide 1 receptor agonist, the next step is the basal insulin. If the basal insulin alone is insufficient, a stepwise addition of bolus insulin is recommended based on the HbA1c level and the glucose profile. Another important aspect of the management of type 2 diabetes is when should insulin be started early in the disease. In certain cases, early initiation of insulin therapy is preferred, particularly in patients who have a severely elevated glucose levels, like with the HbA1c of greater than 10% or glucose level of greater than 300 mg per dl. Or if the patient has ongoing catabolism, that is significant weight loss, or if the patient have symptoms of hyperglycemia including polyuria, polydipsia, excessive fatigue. All these patients may require insulin initially. They can often transition to other medications once the acute hyperglycemia and the glucotoxicity resolves. Another very important aspect in the management is how should insulin be intensified in the treatment of type 2 diabetes. When a patient with type 2 diabetes requires insulin intensification, the first step is typically adding a basal insulin to their medication regime. Starting dose is about 0.1 to 0.2 units per kg per day, that relates to about 10 units per day. The dose is then increased using a validated dose titration method, typically by 2 to 4 units twice weekly or by 3 units every 3 days until the fasting plasma glucose level reach the target of about 80 to 130 mg per dl. It's crucial to assess whether the patient can titrate their insulin dose at home or require more structured guidance such as weekly check-ins to review the glucose data and adjust the insulin accordingly. A clear dose titration plan is essential to prevent the clinical inertia and helps the patient reach glucose control efficiently. Patients should be educated about their glucose targets, what to expect in terms of insulin dose adjustments, and the importance of adherence to the titration plan. Now, what about when to add the bolus insulin? If the fasting plasma glucose target are met but the HbA1c goals are not achieved, then the bolus prandial insulin may be needed. A bolus insulin product can be added to the largest meal or the meal causing the highest glucose spikes. Starting dose is about 4 units, which can be increased by 1 to 2 units twice weekly based on the postprandial glucose levels. The target postprandial glucose levels are less than 180 mg per dl. If needed, additional bolus insulin doses can be added to other meals to further optimize the glycemic control. This stepwise approach ensures safe and effective insulin therapy, minimizing the risk of hypoglycemia while helping patients achieve optimal glucose control. So this was all for today. Diabetes management is all about balance between medications, diet, exercise, and lifestyle. Whether it's type 1 or type 2 diabetes, the key is personalized, adaptable, and evidence-based treatment. If you found this information helpful, don't forget to like, share, and subscribe to Method 360, where we simplify medicine for all. I thank you all for watching. Stay informed, stay healthy, and see you in the next video. Goodbye.